What's up, guys? Welcome to the PT Good podcast, where we talk all things ortho, from physical therapy to training. My name's Kane.
And my name's Mark.
So, Mark, what is on the agenda for today?
All right, Kane. What we want to talk about today is red flag screening, the kind of questions we're asking, the kind of conditions that we're looking for. In addition to that, we want to look at options for referral if we do identify that they have some kind of condition that requires additional care. Another thing we want to talk about are patients who are slower responders, certain presentations that we see clinically that may take more time to respond to PT treatment. And again, when it comes to referral, we want to look at when it's appropriate and the type of referral that's appropriate for patients who are responding more slowly. So, Kane, do you have any kind of questions that you asked initially when it comes to looking for red flags for determining if someone is safe to receive physical therapy treatment?
Yeah, sure. I have a template pretty much that goes through the general red flag screens that I think that most of us are pretty familiar with. I know Mark and I have like very similar templates in regards to this, but they usually consist of like, okay, is this person age appropriate? So if they're like 50, 60 plus, are there additional things that we need to be concerned about? So cancer is definitely one of them if that fits into the boat. Being osteoporotic is definitely another thing that kind of ties into that as well. When you're at that age, am I more likely to suspect like a potential heart condition or anything along the lines of that? And the answer is probably yes. So
Mhm.
I think that just because someone is over that age, it doesn't necessarily mean that those things are wrong or that there's something that's going to pop up. But it's definitely something that should be a little bit more on your radar at that point, just because they're more susceptible to developing those conditions. Some of the other questions that I generally will ask are like any history of cancer for yourself. Like the biggest predictor for cancer is a previous history of cancer. So just making sure that that's on your radar is really, really important, because if something in your exam pops up where you're like, this isn't responding mechanically, I think that there's definitely a chance that something more sinister could be going on. And it's important that we rule that out and that we actually understand the risk that is potentially involved there, because these things aren't like common. They happen, and it's like 1 to even less than 1% of patients that we'll see that present with something like this. But the fact that they still exist means that we're gonna run into it at one point or
Yeah,
another.
at
That
some point, right?
we're gonna have to catch one of these red flags and make sure that our patient is safe, that they're referred to the correct referral, and that they receive the appropriate care that they need. Um, the other questions are like any recent infections, any recent unexplained weight loss, or night pain, like an inability to sleep or waking up because of the pain and you can't go back to sleep, or other like neurological red flags that pop up, like changes in your bowel and bladder habits, changes in sensation or numbness and tingling in your groin area, like or an inability to lift your feet, or you notice that you're just tripping all the time, different things like that, or loss of grip strength. Those are like our general baseline questions that we ask for red flags, and I think that they'll catch like an overwhelming majority of different red flags that we want to be on the lookout for. And just because someone has one, it doesn't mean like, oh, we got to refer you
Yeah.
right now. Sometimes it just means like, hey, that could just be their norm, or maybe we have to better interpret their information. Like sometimes patients come in and they say, oh yeah, I have night pain.
Mm.
I'm like,
Yeah.
okay, does it wake you up at night, and does it keep you up at night? Are you able to kind of roll back and go to sleep? Why are you having difficulty sleeping? And asking those questions, and they may respond with, oh, sometimes the pain wakes me up, but yeah, I can usually go back to sleep, or
Yeah.
it's uncomfortable to lie there for a little bit and then I'm able to go back to sleep. But for some patients, they're like, no, I wake up and it's like it's there. I cannot go back to sleep. It happens every single night and it's consistent. And that's where maybe that's something that we need to pay a little bit more attention
Yeah,
to.
where like it's yeah, like night pain's one that has to be further contextualized, right? It's a different presentation in that. Maybe someone's like, yeah, I when I lie down to go to sleep, it's fine, but then I wake up and I try to fall asleep on my back, but then usually when I wake up on my side and my hip hurts, but then if I roll over back onto my back and it takes a couple minutes, I fall back asleep. Versus, oh no, at night when I go to sleep, it hurts and I can fall asleep, but then I wake up and I have this unrelenting pain that I usually don't get during the day. And it doesn't matter what I do, it's there. And then so I kind of fall in and out of sleep, but it stays painful. And then by the time it's morning, I've only slept like an hour or two and it still hurts. But then during the day, it's not as bad. I don't have that same kind of pain, right? Versus like if someone tells you, yeah, like, oh yeah, it hurts at night. That's not the kind of red flag night pain that we're talking about, right? Similarly, like there's some other kind of, red flag type questions that, yeah, we have to contextualize, right? Like if we're looking at a cervical type presentation and someone says that they have some kind of like dizziness and something like that, just that on its own, yeah, I mean, it's on our radar, right? We're looking for things, but we need to ask other questions along with it to have a better idea if it's something that requires a referral, right? So just, maybe they have neck pain and, oh yeah, I get some dizziness, but I only get the dizziness when the pain's really bad, and the pain's only really bad if I sit for a while, but if I, the dizziness goes away when I, sit upright and hold it, right? Different kind of thing. We see a movement component versus, oh yeah, I have this neck pain, I got a headache, and, it makes me nauseous, and then I get dizziness with it, and the dizziness is so bad I have to sit, and it takes me an outright, like, different kinds of presentations. So we don't have to jump straight to a conclusion that would lead us to think that there's some kind of grave condition going on. We have to, we can ask these questions and contextualize them within the context of the patient. Yeah, you mentioned about like infection too. Like I mean, fever's one like I definitely look for. It's not very high on my list, but if I'm suspecting something and things are weird, maybe you know, they're just kind of sick in general or things aren't adding up. I mean, at least the clinic I work in, we have, thermometer digital and regular thermometers available just to be able to like take temperature. Rarely do I do that. A lot of the simple things you mentioned are like really important. They're going to capture a large majority of the population who needs referral to the red flags. Like you talk about history of cancer, mentioned blood pressure, different kinds of medications that someone could take. A presentation I see not very commonly, but when it comes to red flags, which you touched on, older osteoporotic females, like, with no trauma, they just kind of, maybe develop some kind of spine pain. Maybe there's some positional component, but it's more general. Yeah, I've had, people get compression fractures because of that, just, that go to twist or bend, something like that. So that's another big one I look for. Other kind of things, such as, just general feeling unwell, weight loss or gain greater than, 5-10% of body weight, something like that. I mean, we don't have to get too specific, but especially someone's like, hey, like I've lost like 20 pounds and I've just been eating the same as I usually do. It's like, that's different. Or maybe someone's lost a lot of weight and, oh yeah, I've had this, this upper back pain and it kind of wraps around to the front of my stomach and I just haven't had any appetite for like 2 weeks. I try and eat, but like I'm not really hungry. All right, that's a little different than, oh, I have back pain, right? So yeah, simple questions we can ask, but they seem to cover the majority of the conditions that you're looking out for that could present as a musculoskeletal or orthopedic type issue. Anything you want to add to that?
Yeah.
Anything you look for? Yeah.
Yeah, for sure. I think with the rise in usage of GLPs, I think that's super, super important to clarify that question of, hey, and obviously before you go into an eval, you should be chart reviewing to see what their previous medical history is. right? But if you see that they're on a GLP and you ask them, hey, so any recent unexplained weight loss, and they say, oh yeah, I've lost like X amount of pounds, and you're like, I see that you're on a medication. Is that the reason why you're losing that weight? And they're, oh yeah, for sure. And to me, that is an explained reason. Or if they're like, oh yeah, I'm on a diet, those are all explained reasons.
Right.
But it's often phrased as the I wish question, like, have you any unexplained weight loss? Oh, I wish that were the case, but most of the times, like, if there's no rationale, just like what Mark said, you've been doing your normal day-to-day thing and you're noticing like your weight is just falling off, that is definitely a pretty big worry or concern, where you may have a red flag on your radar to make sure, hey, are there other symptoms that are kind of lining up with this? And the other thing is just making sure that the pain that you're seeing is still mechanical. If it's non-mechanical, if it's not responding the way that we would anticipate, does that mean that there's something else that's going on? Is there something that's more sinister, or is it something that is just like takes time, more irritable, or anything along the lines of that? And that comes with like clinical decision making too, of determining like, hey, is this something that seems right, or is it something that like we should be a little bit more concerned about, because this stuff doesn't happen often, but it'll definitely still pop up. And I think one of the big things that Mark talked about is like for females over the age of 65 and who have the potential or are already diagnosed with osteoporosis, is the concept of a compression fracture. Sometimes there doesn't need to be trauma. Sometimes there doesn't need to be a fall. And this can happen for any bone or joint, really, where someone has a misstep or they stumble. It's actually been stated that sometimes the fall itself didn't even cause a fracture, but it's the actual force of catching yourself that creates a lot more force that can potentially lead to a fracture. So asking those types of questions are really helpful in regards to determining whether or not something like that is present. And to me, it's like it's helpful to refer them out for them to get imaging, confirm it, and that just helps us. It improves on our ability to formulate a better plan of care for our patient and to inform them of their prognosis. Because if it's a compression fracture, do we expect it to rapidly change the way that we would for a case of like responding low back pain? Absolutely not. That thing's got to heal. It's going to take time and it's going to be consistently painful. So it's one of those things that we if we have that information, maybe it doesn't change your treatment, but it certainly will affect your plan of care and your prognosis as well too.
Yeah.
So I think that that's definitely important to have on your radar.
So if you suspect something's going on regarding a red flag type presentation, who do you refer? We can keep this brief, but is there any kind of process that you follow when it comes to who you're referring to when you refer? Do you reference any specific guidelines when it comes to referral or imaging, anything like that?
Yeah, so most of the times the biggest referral that I will make at this point is an infection or the potential for DVT. I think in just this past year alone, I've caught about like 5 different DVTs, and I've had the case for like 2 potential sources of infection. And so when that happens, a lot of it depends on like your relationship with your surgeon, the different like resources that you have available to you at your clinic, where if something doesn't seem right, I have people that bounce ideas off of, like, hey, can you come take a look at this? And the way that our system is set up, it makes it really easy for me to get in contact with the physician. And same thing for the patients too, where I can also just take a picture and upload it, and that way they can see like, hey, they're presenting with X, Y, and Z, and like this is what they're complaining of, and this is what their incision looks like now, or what their calf looks like now. Do you think it'd be wise to send them to the ER or to you for an intervention? And I think, especially like in the cases that I'm thinking of, those are all following a total hip or a total knee. And just being able to use like a criteria is very, very helpful. Like the Wells prediction criteria is just such a huge one when it comes to determining whether or not someone has a DVT. And
Yeah.
I will tell you, hey, some of the DVTs that I've seen do not appear as a DVT. They have virtually no pain. They have a tiny bit of swelling. Maybe it's a little bit more tender, but they just had surgery.
Yeah.
It's hard to really determine that.
Some overlap there, right? When it comes to the present,
sure.
You expect some of that swelling.
Yeah, like your expectations kind of change. And so I remember I had a patient who was just like, yeah, I have a little bit of swelling, hardly tender. Like he had a meniscectomy and he was doing super well, no issues in regards to anything he was doing. I saw him on his second visit, his first follow-up, and he's like, yeah, everything feels great. I just have like a little bit of swelling. Is that normal? And to me, I'm like, it kind of is. Like, you just had surgery. You're going to have swelling. It's going to flow downwards, but as I kept taking a look, I'm like, it really doesn't hurt to get another pair of eyes on it. And so I just ended up referring him back to his ortho surgeon just to make sure that there isn't a chance for a DVT. And this guy was young, and lo and behold, he had a DVT. And I was like, wow, what are the chances? Literally did not fit in any of the Wells criteria, very low risk score. And I was like, oh, who would have thought? And then on the flip side, there are other patients who have a significant amount of swelling that's like only on the one side, obviously. Yeah. Like redness, it just looks
a bit more obvious.
Angry. Yeah. And I'm like, oh, this is a problem. Let's send you.
Yeah.
And they're like, yeah, there's nothing going on. I'm like, you've got to be kidding me.
No way.
So it's just one of those things where it's like, sometimes it's better to be safe than sorry. The risk when you run the Wells criteria, I think, what is it? Like, if you even score if you get one thing on the criteria, I think you're already at like a 20 to 35% chance of having a DVT.
Yeah.
And I'm just like, that's wild. Like, if you have one thing, does it really hurt to send someone just to get a quick look and check to make sure that they're good when the risk is that high?
Yeah.
Yeah,
and usually they can get it done same day. They can just go to the ER or whatever, and it gets done right. Like, get it checked out.
Yeah, it's like, if that's something that you miss, that's a big deal. You want to make sure that you cover your bases, that your patient is safe. So I think that is a huge thing.
Yeah.
But while we're on the topic of like DVT and infection, I just had a patient the other day, and I made the assumption that his incision was healing, right? And so this is like something where it's definitely a learning moment. And what happened was he had a pocket of like delayed wound healing. And I had two patients, like literally back to back. One of them, same exact thing, messaged the doc, sent a picture, and he's like, nope, it's all good. We'll just change the bandage and then just let it continue healing. No issues there. Now, when it came to this patient, I just checked his incision a couple of days ago. Everything was good. He's been checking it, keeping an eye on it. Everything was good. And then the last session, I didn't check it. And he didn't say anything. Everything was good. I was like, have you been keeping an eye on your incision? Looks well healed. And he's like, yeah, everything looks good. It's one part just like, it's the same thing as last time, just hasn't really, isn't closing. And I was like, okay, cool. And so we just kept going on from there. It wasn't like a significant change in status. And
Mhm.
then yesterday, actually, he comes in and he's like, "Hey, so I have to cancel PT for today. I got referred to wound care." And I was like, "What?" And so he's like, "Yeah, the incision started becoming like necrotic. It started turning black,
Oh, yeah.
and then they had to do a debridement and then get him on, like, make sure that everything was clean and everything. They still said it was delayed wound healing. They didn't give him anything else. They just cleaned it up and then just patched him up and kept him going. But that is definitely something that, like, I missed. I should have checked it. Maybe I wouldn't have even seen it on that visit, but it's still something to keep in the back of your mind. He ended up seeing it yes or 2 days ago, messaging the doc, and the doc was like, "All right, let's send you in, get it checked out, see if there's anything going on." And that's when they made sure that, like, everything was cleaned up and good. But the reason why I mentioned that is because he quit smoking for his surgery, which is a requirement for the surgeon that we typically get a lot of patients from for his total joints, is that they're not allowed to smoke before the surgery. And he got back on. And then that is something where I think it's important to ask, do you have a history of smoking, and how much and how long? Because it impedes, like, your healing time. And
Mhm.
that's definitely something to keep in mind.
Yeah, definitely. Do you follow any kind of when it comes to referring for imaging? Any kind of guidelines you follow? Anything you look out for when you think, hey, it's time to get an X-ray, MRI, things like that?
Yeah, sure. I think and this comes from my residency training, because previously I didn't know about this, but it's the
Hmm.
ACR imaging
Yeah, yeah.
guidelines. And people fit into these clusters, and I think that the ACR imaging guidelines are very specific. They are helpful in determining, like, in following an algorithm. The problem that I have with them is that they can be very cumbersome to use, because you need to find I forget the term that they use. I believe they call it like a mutation or something like that. It's like
Okay, yeah.
like a form of, like, what the patient is presenting with, and you need to make sure that they fully match up. But a lot of times they end up being similar in
Hmm.
the long run. So I think that's where knowing when an X-ray, CT scan, MRI, MRA, etc., is warranted, and then just chatting with your physician that you're referring them back to, making sure that, hey, something's not right. Like, I think that imaging may be warranted.
Mm.
Some physical therapists are very specific in what they tell their surgeons. I don't think that that's really necessary from my perspective. I think that I may mention, like, "Hey, do you think an MRI would be warranted?" But most of the times, I just leave it up to them and say, "Hey, do you think that further imaging, or what would you do in this case?" Just leave it more open, so that way it doesn't feel like you're trying to do their job for them. I
Yeah,
think
that
that's
it opens the communication a little bit too. You can give your perspective, you are asking for their perspective, and then yeah, at least have another professional who is you're discussing with too, so that you have a better idea if the recommendation you're making is appropriate. At least in my experience, like most physicians are, respect your opinion, and if you're asking for a certain kind of imaging, as long as it's appropriate, they're willing to put an order and things like that. But you want to make your case too, right? You can't just, you have to have a good reason for doing it.
Yeah, and I think that that's, like, one of those things that you just need to make sure that you've covered your bases, that you're not just like, I think it's
Mm.
funny because we always joke about how patients recklessly, or not recklessly, but needlessly, get imaging done.
Hmm.
But yet here we are, we're like,
Uh,
we need to make sure that this is what they actually need.
yeah, yeah, yeah.
Um, eh, it's erring on the side of caution, but also just making sure, like, hey, are we being overly cautious? Is this something that they really need? And using your clinical decision making just to determine, like, okay, are we wasting our time and the surgeon's time and the patient's time, or is this something that could be potentially more sinister, that needs another, like, team member to help take care of? So we've already discussed differences for or like red flags for cancer, for DVTs and infections following surgery, but the other thing that I wanted to kind of chat a little bit more about was potential neurological red flags.
Mm.
Like I know like my usual screen is like reflexes, upper motor neuron screens and stuff like that. What are some of the other things that you typically look for, and what are some deviations in like reflexes or upper motor neuron stuff that you look for and see, and
Mm.
how do you compare those findings, Mark?
Yeah. So when it comes to like a neurological screening baselines, like I talked before about the dizziness, maybe like lightheadedness, stuff like that. The presence of like paresthesia where that doesn't match it just kind of like, especially if it follows like a bilateral, maybe a systemic type pattern. Oh, I just feel it in both my legs below my knees. Doesn't change. It's always there. It's worse at night. Okay, that's the same thing. What is it? Like stocking glove pattern. Is that what they call it? But you know what I mean?
Yeah,
Like it's
yeah.
both sides. It's equal. It's not different. Insidious on. So nothing else going on. I look at that for any kind of spine. Okay, do you find you're catching your feet? Have you fallen at all? Yeah, we talked that can tie into a little bit of the dizziness stuff like that. People who have neck pain. Okay, you dropping things. You have weakness in your hands. Do you feel like you have a loss of grip strength or dexterity in your fingers? That's another big one. Reflexes are interesting for me because there's a bit of nuance here in my opinion. We have to contextualize it. I feel like so many people I could give a 1+ on their reflexes just because, or even like a 0 because they're guarding to some degree. They know what I'm doing. I try and distract them, right? I don't really do the thing where they grip their hands and close their eyes. If I'm hitting zeros, it's the same bilaterally, and there's nothing else sticking out that I think would be a red flag neurologically. Um, you know, if it's a reduced reflex, I'm not putting a ton into it. If I hit them and it flies and it sticks, then I'm looking more, right? I always, especially lower extremity, like I'm there, I'm down there. I'll do a rapid dorsiflexion. I'll look for clonus too. I've only had that present twice, but both of those people had, like a their reflexes were like, I'd do a L4 and it would just like fly off the table, So yeah, if it's a heightened response to reflexes, I'm more concerned than if it's like a lessened response, especially within the context of the individual, right? So yeah, that kind of covers what I look at neurologically. Um, Myotomes are big too, right? If I'm noticing like a bilateral pattern of strength loss or sensation, like I talked about before, that's cluing me in. Balance changes, visual changes, dizziness, lightheadedness. I'm bringing that together along with like the reflexes, and I'll test clonus as well. Anything else you look at neurologically?
Yeah, I think that comparing them side by side is definitely important. And
Mm.
like Mark said, it's very contextual in nature. So if someone is like not presenting with any other things in regards to their history, to me, that's just how some people are, maybe a slight difference, or maybe noting like hyporeflexia or hyperreflexia, as long as it's like relatively equal bilaterally,
Yeah, yeah.
not a big deal. Reflexes are not something that's like, oh, it's going to be consistent
It's not black
and
or
it's going
white.
to
Yeah,
stay
it's
like
just kind of
this.
like,
Yeah.
yeah. Sometimes I have people
Yeah.
like come for their back, and they're like, "Oh, the doctor said like my reflex is gone on my legs," and you know, you test it, and it's like equal bilateral, but maybe not like a 2+ or whatever, and it's just kind of like I don't know how important that is.
Yeah. The one thing I will say that I don't do super often, but I will do it enough. Like when I get a reflex, sometimes I don't if it's a little bit odd to me, and I try to get a couple of reflexes, but the way that I was trained was to get several
Yeah,
reflexes,
I think
or like
it was like wait several attempts on the same reflex or multiple.
several attempts on the same
Yeah, mine
reflex.
was.
So
I
you
think the number I learned was 6.
Yeah, and
Yeah,
I was taught like five
yeah,
plus, somewhere around that range, just to determine if it fatigues or not.
And
And
you hit it, let it reset, and then hit it again. Not like you're just like whacking them, right? So it keeps bouncing,
yeah,
right?
exactly.
Yeah,
So
yeah,
it's
yeah.
just like it's important to note that, and if there's like a change there, and if it's something that you should be worried about. And Mark touched on a lot of the other things too, like for cauda equina, like the numbness that goes down, the stocking glove syndrome. I think it's definitely something to take note of. Different things along those nature in that nature to just kind of clue us in into saying like, hey, is this something that is more neurological? And there's also like upper motor neuron screens that we should take a look at too, and that would be like quick and easy, just talking about like inverted supinator sign, or like clonus, babinski, stuff along those lines. I think it's like so fast, and just making sure that you cover your bases when you need to.
Yeah, and that's the most important part. Covering your bases, make sure you test things. If it's not, if the presentation's different enough and it's not adding up, yeah, like refer. See what the PCP thinks. See what the referring physician thinks. If it's post-op, see what the surgeon thinks. Just you know, take it within the context of the individual, the presentation, whatever they have going on. If it's just a single quote unquote red flag thing, maybe not cause for alarm, but things aren't adding up. Yeah, a referral may be necessary.
Yeah, and the last thing that I want to touch on briefly is just AVN, or avascular necrosis, and it's just because I this topic holds a place. I guess that's kind of near and dear to me because I did a research presentation on it. But I've had two patients now where they had cases of, actually three, where they had cases of AVN and it wasn't caught. And so one of the big things that I started looking out for more was prolonged corticosteroid usage, especially like injections, or if they have an autoimmune condition. And the next thing is alcoholism, because it leads to that. And like I think it's interesting because that's how two of the cases that I treated had AVN, was that they thought that it was bursitis or something, and they just kept getting injection after injection. And the most recent one wasn't even doing anything. She's in her 70s, and all of a sudden she has a hip fracture just from literally standing and walking, and just boom, just goes. And so that to me is something that we really need to be mindful of, just to keep that on the back burner. If something's not adding up, make sure that we're on top of it.
Yeah, 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 exactly. Yeah, being on top of it, knowing, yeah, just know what's going on.
All right. So I think that kind of segues into the next part for us, which is determining whether or not we should be referring patients. And we talked about like these red flags. Sometimes they're not in an automatic referral. Sometimes that's just how they are. Totally normal. Like to find some of these things, like maybe one finding, right? But we have to make sure it's contextualized. Does it fit? And so there are other patients where I feel like it's harder to determine whether or not they need that referral. And that's for patients who are slow responders or non-responders even. Like, what exactly do we do? Who do we refer them to? And what exactly are you looking for in your criteria to determine that a referral is the correct move? Do we refer? Do we refer and treat? What exactly are we doing? So,
Yeah, and
Mark,
we're
what
assuming
is like,
that like we've cleared red flags at this point. We're talking about, all right, we have a patient, seen them for a certain amount of time. We'll classify them as like a non-responder, but we don't think there's like a sinister condition occurring.
yeah, so
Yeah.
like what are some of the things that where like you see something for, like, I don't know, a shoulder or a low back pain, or like a spine patient, I should say. And then like how do you determine, like, have we exhausted everything? Do we
hmm
do they need more time, or is this like, no, you need to go?
Yeah. So, I mean, I'll talk about it again. Test, retest, looking at the symptomatic response when it comes to treatment, any kind of treatment, right? So, the first thing I'm looking at when it comes to someone who I think may just take more time is a consistent symptomatic response of the symptoms increase or decrease, but they don't remain worse, they don't remain better in regards to any kind of movement. And it can be variable, but it's consistently variable in that we aren't finding a single movement that is consistently relieving their symptoms, right? So maybe it's something where they come in one day and they're like, oh yeah, that, that movement, it helped while I was doing it, but it didn't stay better. And then they come in for the next visit, and then that movement makes it worse. And then we try something else and it makes it better. But then they come in again, and it's just kind of all over the place. Like I said, that consistent variability in terms of symptomatic response is one thing I look out for, where I know, okay, this person may respond with time, but they're going to require time, right? And the retest is going to allow us to know that, right? So we're still testing, we're still reassessing that it's still consistently variable. And then we're just comparing other baselines to get an idea. Okay, maybe we do our treatment for 4 weeks and yeah, we reassess and they're starting to improve, but it's still variable. Okay, in that case, our management strategy, our exact treatment, what we're doing to help the person is different than someone who has like a clear directional preference or response to a certain treatment. But we can confirm that, hey, this is beginning to slowly resolve with time, and maybe they're just going to require more time compared to someone where it's like, all right, we know this movement helps, you're going to keep doing it, and then they're done within a couple visits. Yeah, so that's what I look for in like slower responders. As long as we can get an idea of like track it over time, see what's happening, that I think gives us like that to me, at least in my practice, seems to be like the best indicator of someone who will respond, but slowly, right? I don't have a hard cutoff when it comes to how long. I'm kind of getting a feel of the patient, like where they're at with certain things. So if I go for 2 months and their chief complaint isn't maybe maybe improved by at least 50%, and it may even be before that, it could be later. I'm typically checking in with the patient and framing it as if, hey, we've been doing this for this long. You've told me, and we can demonstrate that you've improved in these regards. Our options are to, you could see you could go back to ortho or spine and pain or whoever, and they could see if they can offer you anything extra to see if they could help you faster, or we can keep doing PT. You're going to keep doing your home exercise. You can come in and reassess to make sure we continue on the right track. And it may continue to take longer, but I think you'll continue to improve. So I'm leaving it open. I'm giving my recommendation based on the information I've gotten from them as I've been reassessing, and then kind of going from there. Like I said, in the absence of any kind of red flag condition, if they're slowly improving, like I give them the option to follow up. I do make sure and tell them, like, hey, like, typically if you're going to go back to see, let's say it's shoulder or spine or whatever, like if they may offer you a kind of injection or medication. In this case, since you're slowly responding, like if it's something that you want to see if it could help you more quickly, I think it could be appropriate, but I'm also not strictly recommending it. I'm kind of neutral, right? They're kind of improving, quote unquote, with PT, whether it's PT or just time. But, I want to give them an option too. I don't want to say like, hey, you're going to have to come here for 4 months before it's gone. I could say, hey, you do meet the criteria and it may be appropriate for you to, receive an injection or something else. I'll leave that up to whoever I'm referring them to. But yeah, that's kind of how I go about it, right? So I just let them know I think it's going to take time. I can demonstrate to them how they've improved over time, but I give them the option to, follow up with a different provider to see if there's anything else that could help them more quickly. How do you approach it, Kane?
Yeah, I think that is something that I have changed with time and with more and more experience, for sure. Where before I gave too much time, where I would think, okay, maybe I just haven't exhausted everything. Maybe if I do this, or maybe if I do that, or maybe it just needs time. And
Yeah.
so I've definitely been guilty of this, where I keep patients on for too long before I make that referral, because I don't want docs to think that I'm wasting their time, or that I just haven't done my job or due diligence. But I realize that there's a couple of things. When you make a referral, the patient is not getting in right away. You have that time. It's better to schedule that ahead of time. That way they have the appointment if they need it. And then also just keeps the doc in the loop. The other thing is you have the ability to cancel that appointment.
Yeah, exactly.
That's totally normal,
Mhm.
right? It's totally fine to do that. So to me, if I see something where I'm like, no, this is presenting the same way that I've seen previously, where I needed to make that referral, where I don't like where this is going, I'm going to keep you on for another couple weeks. And if nothing changes, that's where we're headed. And I am very, very transparent when I talk to my patients. Like I tell them, hey, this isn't responding the way that I'd like it to respond, or the way that I would expect it to. And so if that's the case, it doesn't hurt for you to get another pair of eyes on you, like making sure that you need imaging if it's warranted, or maybe you need an injection if it's warranted. It's not often that I refer patients for an injection for anything else aside from their spine. It's very rare, actually. There's only been like one instance, I think, where the patient and I were on the same page, or actually the physician and myself were all on the same page, where I was like, try an injection, see if it helps. And the thing that I think is really interesting here is when you get an injection, it's the same thing as any other intervention. It is useful as a diagnostic tool, because if you get an injection and it doesn't help, hey, maybe that's not what they needed. Maybe it's not a chemical component that needs to be cleared out. Maybe it's not just inflammation that needs to be calmed down, right? Maybe it's an actual mechanical issue, or maybe there's something else that's going on, like we talked about red flags earlier. So I think that doing or using that information for you to help determine whether or not like they're going to respond well with that, or whether they do or not, that kind of affects what your plan of care is going to be, and what you should do moving forward. Because if it doesn't work the first time, is it really going to work the second, the third, the fourth time?
Yeah.
So I think that's definitely really important. So there are certain criteria of things that I look for, right? And the things that I usually look for are, is their pain proportionate? Is it something where it's just like, I can't do a single thing right now to alter your symptoms? They are way, way too irritable. Like they are just not appropriate to be for PT based on their level of symptom irritability. And to that, I'm like, hey, maybe we just need to let it calm down more. Maybe it's time. Maybe you do need medication to get it to calm down, so I can at least see and examine you. There are patients where I can't even examine because they're so flared up. And when that happens, I'm just like, I can't change anything right now, because that's just the nature of it. And the other one would be like non-responding symptoms. Like if you have like someone who has radicular symptoms, and you move them and everything makes it worse. There's just no shot. Every single motion that they do gets worse. It's not even staying the same. If it stayed the same, like to me, it's like, sometimes it's like, it could be okay. Like maybe it needs time. If it only gets worse, then I'm like, oh, that doesn't seem the best to me.
Yeah.
Right.
Yeah.
And we'll talk more about like the differences between symptoms getting better, staying the same, or worsening. Usually Mark and I will agree that if a patient's symptoms stay the same, it's not really useful information for us.
Mm-hmm.
Like we want to make a change. But if it is only getting worse and fast and disproportionately, I'm like, hey, this is not it for me. This is definitely telling me that something else that I need to consider. And I want you to get back in and see if you need something else that I just can't simply give you. Maybe it is that injection. Maybe it's another consult with spine, and just to see what else they can help in regards to that. You know.
Yeah, I find people as early on in my career, I thought that the expectation when people came to physical therapy was that that was going to be the solution for them. But as I got more comfortable in my practice, I feel that our job is to help people, or at least attempt to help people. But as if you gather the correct information and you start to notice these presentations that may not respond and they don't respond, our role changes. It's to be able to assess people and attempt to treat them, or even if the treatment isn't necessary, just assessing them and knowing if this is the appropriate management strategy for them, right? And if not, we're able to refer, right? I know, like in some companies, including ours, we have a system in place for spine pain, where it gives us the tools to be able to refer where we think it's necessary. And we follow certain guidelines to be able to do that. So if we notice a presentation or we find that this is just like a presentation that's not responding, or if their symptoms are just consistently remaining the same and aren't staying improved or worse, and we're just not getting any information, something else has to be done.
Yeah, and I think that that's where we talked about this previously, but like when we're going through our exam, or our initial eval, is determining, like I always say this, like when you've been practicing for a while, your eval is fully scripted out. It's fairly standardized. It's tailored to the individual based on what they say. But for the most part, you've done it so many times that you're on autopilot. You know, it's like, okay, these are my expected findings. Here's what it should be like. And like, this is the pattern they should fall into. When things don't go the way you expect them to go, that's when I say your autopilot should turn off. You should be like, hey, whoa, that's not what I expected to find.
Yeah.
Maybe it's a significant change in their range of motion, and it's not equal. Maybe it's like what they said during their history, where you're like, oh, that doesn't sound quite like low back pain. And so when you get those things, that's when you're like, oh, I should be on the lookout for this. Like, it's not matching up. So I have one example, and this was when I was with my mentor, and Mark knows who this is, where I had a patient who was painful with everything that I did. It wasn't like disproportionately painful, but it was one of those where I was like, it is more than enough for me to be like, this doesn't seem right. Everything made it worse, did not really respond. You'd get like no better at the very best. And I saw her on my eval, and I was like, this really seems off. I gave it like two or three more visits, and I was like, okay, I think this is the point where I'm like, the only thing I haven't tried now is dry needling, for example. And I was like, it's not responding mechanically. I think it's time for a referral. I spoke to my mentor, and he's like, no. You've just given it like 2 or 3 visits. It's give it some more time, see what happens, see what we can do. We're going to exhaust this. He comes in, we do another mechanical examination. He's like, no, she needs to go. She needs to go now. And so the tough part about that case was she went to Pain and Spine, got a myofascial, or like a muscular injection, for myofascial pain, instead of what I anticipated was going to be an epidural. And I don't know, like, because I couldn't change her symptoms, she got no relief from that injection. And to me, like, I wasn't able to continue treating her because of that plateau. Like, she was able to do stuff, but she just consistently had that pain, and it just would not change. Eventually did try dry needling, did not do anything, actually made her worse. And so to me, it was a question of like, is it something that's mechanical? Is it changing? We just hit a hard plateau and we weren't going anywhere. So I think that that's like a case where you kind of start to realize, like, this is fitting a pattern that I've seen previously. I should get you in sooner rather than later. It doesn't hurt.
Yeah,
So
exactly. Like you said, you've kind of you exhausted everything. It's not adding up. What else would you do? Yeah, time can be a component, but is there something that, especially in those cases, like is it really, um, like you said, it wasn't adding up to begin with. Like if we wait another week or two, is there going to be something? Are they all of a sudden going to come in and just be like, oh yeah, actually, it's better, which can be hard to tease out unless you've seen like enough consistent like slow responders that you feel like it's going to take time. It's a bit arbitrary, and it's kind of it's hard to know when you've done enough to say it's over. I mean, if you go, in my opinion, if it's like 3 weeks or like 3 to 4 visits and there's just like nothing happening, or you're not getting improvement. To me, that's enough, right? I'm just like, all right, this is.
it's
But
not
if
it.
it's, but yeah, exactly. But if it's like, you know, each week, they can move a little bit better. They're like, oh, actually, compared to last week, it's not. I still have pain. It's not as intense. It's like, okay, we can ride this out a little bit, right? We can keep going. But I think it does require a little bit of practice. There's a bit of a soft skill too, just to kind of feel it out, right? But
Yeah, I would definitely agree with that.
yeah, how about are there any presentations that you see, and I think this will be helpful, that you notice, like, okay, you have someone coming in, they have these kind of symptoms, and they have this kind of presentation, and you're going through your stuff. Maybe it's, you just kind of have an idea based on your experience that, okay, this will most likely be someone who takes some time.
Yeah, it's typically patients who are like more chronic,
Okay. Yeah.
like if they have those types of symptoms, if I'm not making significant changes to them on eval or first follow-up where they're not responding as well mechanically,
Hmm.
that to me is like, okay, maybe it just needs time. Maybe we just have to load it, or
Yeah.
maybe we need to let natural history take its
Yeah.
course, because low back pain and even neck pain tends to resolve on its own with
Hmm.
time. And that's why people have those episodes. But I think that a really important thing here is to know when we've exhausted something. And that's where I think that being a good clinician means that you are systematically going through um, like your plan. And
Right.
I've definitely made this mistake where you muddy the waters. You're like, okay, I checked this out, but maybe I need to revisit it. And I don't know if I like went through everything with it.
Yeah.
And once you go back and forth, you're like, what exactly did I do? What are the
Yeah.
findings that I
Yeah.
had?
You're adding
And how do I
variability to
know?
an already like variable or hard to understand presentation. It certainly won't help you. Yeah.
For sure. I think that comes with more experience, more confidence in your decision making. And that's why Mark and I always talk about having a framework. You need to have structure, because if you don't, you have no idea whether or not you've actually exhausted something. Like and I've learned this from my mentors, and I've continued to apply this, which is if you are going to investigate something, investigate it. Do not beat around the bush. Don't just call it after one test. Make sure that you're actually checking things essentially to failure. Like push, go to end range, use more reps, use more force, do what you need to do to determine there's no change here. Like this is not the right path. And that is where it's really important, because that helps you better determine your scope, your limitations, the people that you can help, and etc. I think that is like vital in ensuring that your patients get good care. Because what if you just weren't as thorough? What if someone else that's a more skilled clinician takes a look and they're like, oh, yeah, they're better. I fixed them. I just did this.
Yeah.
And you're like, well, I did do this, but
Yeah.
they're like,
Yeah.
you didn't do it. You didn't do this. You may
Yeah.
have checked it
Yeah.
out, but you didn't further investigate and exhaust it. So you missed something. And that to me is just like, that is a huge learning moment. Like that is a mistake that you make and you're like, I'm not making that again. Or at least that's how it should be.
Yeah. Exactly. It's kind of like one thing at a time, right? Completely exhaust it. If you think it's like something that's going to take time, take the time, right? But make sure you're doing it. If you're gonna follow a system, you have to follow. You can't just start doing different things that, like you said, muddies the waters, makes it a little bit less clear. It's just gonna make things harder to follow going forward.
Yeah, and I think that this is something that Mark and I talk about pretty often, and I think Mark is definitely better at this than I am. Like if I have a patient who is more irritable, um, there are times where I can't completely exhaust it, or I don't feel comfortable exhausting it. I may move on faster where I'm like, okay, I checked it a little bit and I'm just not getting what I like. I'm going to move on the eval to see if there's something else that I can do to decrease their symptoms. With that being said, I still have that mental note for the next follow up where I'm like, no, we're going to revisit this. We're going to check it out and we're going to further investigate. Maybe I don't want to put them through the ringer on the first day,
Yeah, yeah,
but
yeah.
it's still in the back of my mind. And like I said, Mark and I talk about this. There is no harm in taking more time. Use an extra visit to make sure that you've exhausted it so that you can do a better job moving forward. It's okay. You do not need to have that right answer on the first visit, on the second visit, or even the third. But your job is to collect more and more data to make sure that you're moving in the right direction. At
Yeah.
least it's giving you better indicators of, oh, this is not it. Or, oh, we're moving in the right direction.
Yeah.
I think that's super important for systematically diagnosing and treating people.
Yeah, and we talked about this before, but sometimes you're going to need the patient's help. It's like, hey, we're doing stuff within the 30, 45 minutes that we have together in the clinic. We're not getting the response is unclear. We're not getting a response. This is what I need you to do at home for the next week until I see you. That'll be sufficient time of you completing this kind of movement or certain amount of exercises for us to know if this is going to be the right answer for you. And, regardless of the outcome, it's giving us information we can use to further individualize and further guide your treatment so we know if we're doing the right thing or not. So, if you're in a single instance or a single appointment, if the response isn't, if there isn't a response or you're not getting the response you're looking for, it's not necessarily cause for alarm or that you have to change anything. It just means, it might mean, hey, you need a little bit more time of doing this single thing just so I can know if this is going to help you with time or just what's going to happen as you do it.
For sure, for sure. And one of the other things that I would say is if you have someone where you're just unsure or like you haven't quite figured it out yet or it seems fishy to you, ask your colleagues for help. It is totally fine. Like if you're in a clinic, like you should be able to have these discussions. Like I said, Mark and I have these talks all the time about different presentations. Sometimes they're weird and we figure it out. Sometimes it's just like, no, that's like that they need to go. And that is just so helpful because not only are you learning through your experiences, now you're learning through someone else's experiences too. That's like 2 times the amount of information that an experience that you're collecting and that you're gaining now. So if they're able to give you more ideas, things that you wouldn't typically look for or treat or whatever, especially if they are getting better results, they're just a more seasoned clinician or they have like more advanced training, it is going to do you so much good in regards to being able to know and be confident in the fact that you've exhausted all conservative methods before you make that referral.
Yeah, and with what'll come with experience too is the person's exposure and understanding of that, certain presentation. Maybe they just take a quick look. They're looking like, hey, this is, from what I've seen, it would take some time, right? And it's hard for research to capture those specific things. I mean, part of our practice, evidence-based practice, is experience, right? Or not like strictly from a research standpoint, right? So it's hard to just say, hey, this presentation takes more time. But when you have a clinician, someone who's actively been trying to improve for a long amount of time, and they say, hey, I've seen this presentation, I don't think PT's the answer, or maybe, hey, this is going to take a little bit of time, that can have immense value when it comes to your practice as either like a new clinician or someone who just needs a little bit more guidance?
Yeah, sure. I think that it's certainly helpful to be able to have someone, like I said, to bounce ideas off of, and just to, I don't want to say double check your work, but to make sure that, hey, I'm not going crazy. Like
Yeah, yeah,
I've gone through this, and I'm just not seeing it. And maybe it's like, it certainly could be a skill issue. Maybe you're
yeah,
newer to a system, or you haven't done the system or followed the framework correctly. And that's where it's helpful to take a step back and make sure that you're
yeah,
actually going through
absolutely.
that and doing it well. Now, there's one thing that I do want to tie this back to, and that's, I've had two cases of this,
Hmm.
and this is where Mark said there are times where you have a patient come in, they're not responding, and then the chances of them just spontaneously responding is very slim. And I definitely agree with this. When that presents itself, don't be afraid to make the referral as you need to. But my one patient that really sticks out to me was a patient who spontaneously resolved pretty much. And I couldn't believe it. So this patient came in, had low back pain after picking his mom up after she fell. He is like late 70s, really really nice guy, and I thought, oh man, acute onset ridic, this is going to be easy. We should be able to resolve this, no problem. He became a complete non-responder. Everything made it worse. Like, he just peripheralized, and this is a patient early on in my career, and I just kept him on my caseload for a longer than needed time. I refer him, he gets an injection, he sees some improvements, but it's not enough. We give it some more time. He starts responding more and more and more. And that's great. But then he plateaus, and his symptoms are just so wishy washy. They aren't like clear in regards to directional preference or anything like that. And it kind of changes. There's not a whole lot of carryover. I'm like, okay, still not what I like, but better than before. Send him back. He gets another injection. And in our system, usually if they don't respond to the first injection, they are given a second epidural that goes in at a different access point, where hopefully they're able to cover the nerve root with the injection better. He gets that second injection, and he's improving again. And same thing as before, more improvements, but then a hard plateau, just like very inconsistent symptom responses. And I stayed, like, I stuck with lumbar for a while. I had to go with thoracic, and then eventually we were stuck on like working on his thoracolumbar junction, and that's where we saw the most amount of progress. And then once again he plateaus, and all of a sudden he comes in one day walking completely normal. Keep in mind, he's been someone who like hunches over. He says he walks like a Neanderthal. And he comes in walking fast, walking normal, head straight up, smiling. And he's like, boy, oh boy, do I have something to tell you. And I was like, what happened? So he tells me that there was someone that rang his doorbell, and he went to go outside to go like answer them, but he was going to go through his garage because they were about to do work on his house, and it was a dewy and misty morning, and his garage was open, and so that layer of mist settled in on his garage floor. He runs and slips and literally just goes up into the air. Like, he told me he got like 2 to 3 feet of air time,
Mm.
falls, and he hears a huge pop. And then he was like, oh no, I just ruined months of physical therapy in progress. And he's waiting for the pain to come on. And he stands up and he's like, oh my God, it's gone. All of his pain was completely resolved. And so I always make the joke of like, hey, sometimes you need a therapeutic slip and fall,
Yeah, right.
or maybe he need a grade 6 manip,
He did
because
it.
I've
Yeah,
tried
new
manipping him,
technique.
got nothing, and maybe he just needed to fall on his garage floor to fix it.
Did it. Yeah. Yeah. So a case
Sorry,
of like a
Mark.
slow responder, right? Just kind of, yeah. Sometimes we don't know. It's, like I said, it's hard to tell. It's a soft skill to develop. But as you start, I think with experience and with like actively monitoring patients and seeing a variety of presentations, it can give you the information you need to be able to determine the proper care for people who may be a slower responder or when to refer people. All right, everyone. So what we talked about today, we talked about earlier a little bit of like red flag screening, the type of questions we ask, what we're looking for, the kind of information we're trying to get for these questions, and even if we do get like one or two quote unquote red flags, bringing it into the context of the patient and knowing when to refer. We then transition to the type of patient presentations that we see that may respond slower, the amount of time we're giving people, and the options we have to refer people who are responding slower or who we feel like may need a referral. In regards to the slower responders, we also mentioned that, checking in with the patient, making sure they're on the same page and offering them appropriate options when it comes to further management or at least just referrals is, a key in terms of maintaining the open communication and fitting your role in that situation as a physical therapist. All right, everyone. Well, that concludes today's episode of the PT Good podcast. Remember to leave us a like, subscribe to us on whichever platform you're listening to us on to. Thanks for listening. Hope you enjoyed. We'll see you on the next episode.
Missy, love you. Bye.